So on behalf of IFAM and the Center for Behavioral Intervention Technologies, it is a real pleasure to introduce Dr. Kenneth Dodge, who is the William McDougall Distinguished Professor of Public Policy and a Professor of Psychology and Neuroscience at Duke University. So Ken is a Chicago native. He's a graduate of Northwestern University, so he is returning here to speak to us. After he finished his undergraduate degree, he got his PhD from Duke, went on to a number of prestigious universities around the country, and then returned to Duke, where he is currently a professor. He's a renowned scholar in developmental psychology, primarily related to prevention of aggressive behavior and violence in children. And he has received many awards, including, he was elected to the National Academy of Medicine in 2015 and received the Distinguished Scientific Award for Application of Psychology from the American Psychological Association. And the reason that Ken is here is because he has been one of the leading voices, I think, in our field in psychology to advocating for the movement of psychology away from just individual intervention focus to having population impact. And I think he's going to be talking about some of the work that he's done in that area, including Family Connects, which is a nursing program for that provides home-based nursing to support early childhood development childhood development and prevent child abuse. So please join me in welcoming Ken Dodge.
Thank you. Thank you, David. Thanks to all of you for inviting me here. I would like to talk with you about population mental health sciences, and there's a way in which I feel I'm coming to Mecca in the world of population approaches. Perhaps I'll be preaching to the choir, but perhaps and hopefully I will learn more than you will. I look forward to your feedback. This is an interest and passion of mine at this point. I'm a clinical psychologist by training, and I am wondering if we are entering a new era. I hope we are entering a new era for clinical psychology. Historically, clinical science and practice have been directed toward the individual, toward understanding how individuals develop psychopathology, how individual psychotherapeutic interventions can have an impact. And I want to celebrate all the wonderful discoveries that have been made in so many areas. But as a number of colleagues have said, this approach has had very little impact on moving the needle, so to speak, on population metrics. So a couple of years ago, American Psychological Association held a population health science summit a year and a half ago that was resulted in a report and somewhat of a manifesto about population mental health science. And I'm delighted that there are several Northwestern folks who were part of that group, authors of the document, and I want to acknowledge them there. So the goal, what I'd like to do in the time that I have with you today, is to apply psychological science to a population approach to child and family well-being in the first 5 years of life, and to give several examples, to see if this approach makes sense and what we need to do. Let me start by saying that children and families in the United States are in trouble. Families will tell you that. Objective measurements, metrics will tell you that. And some of the data are just really eye-opening and surprising. The United States is fourth from the worst, fourth from the bottom of all 39 OECD nations in young child 0 to 5 mortality. We can't keep our babies alive. We're also fourth from the bottom in maternal mortality over the same period of time. Estimates show that almost half of all children will have a diagnosable mental disorder by age 18. Kindergarten readiness measures are abysmal. A third of our children entering kindergarten in the United States cannot recognize letters or count past 10. And this is comparatively to other OECD nations toward the bottom. We have problems in environmental determinants, child abuse. We've done studies that up to 25% of all children in a community will be investigated for potential experience of child abuse by the time they reach age 5. I can repeat that, 25% of all children in a community being investigated. And of course, too many of our children live in poverty. Even more egregious are the disparities across race and income groups. Here's just a couple of examples. On the left side there are mortality, deaths per 1,000 births. You can see that the mortality rate by age 5 is more than double for Black children as it is for non-Hispanic white children. On the right, just a couple of more figures. Low-income children are twice as likely to come to kindergarten, not prepared to learn, and Black children are also much more likely to be investigated and substantiated for child abuse. This is not for lack of spending. The United States spends more on healthcare, on child development, on children than almost any other nation in the world, whether it's total spending, which is the green dotted line, or spending per person in poverty. We spend a lot of money. However, we spend it, by my view, too late. So this is A.J. Chaudhry's figures from several years ago. Dollars spent per child in our population annually in the United States. And you can see we spend most of our dollars on children aged 6 to 18. A lot of that's public education, but also healthcare, after-school programs, early job training, all kinds of other interventions than we do on children birth to 5. It's as if we have neglected or not paid attention to children birth to 5. So why have we not attended to all young children and their families? And I suggest several reasons. One is I think we have a historical cultural myth that continues today of that stay-at-home mother who does it all. Right? Don't tread past the threshold because mom is at home, dad's bringing in the bread, winning the income, and mom's doing it all for those young children. That's, of course, a cultural myth. I don't know that it was ever true, but that's part of why our public policies have stayed away from supporting families in early life. Another reason is developmental scientists and professionals of all kinds were simply wrong. The American Medical Association in the 1920s opposed nurse home visiting for families on the grounds that it would do harm to the mother-infant bond. That was their official stance. They opposed federal spending for support for families in that time. Educators, 250 years ago, the United States developed the first universal public education system in the world. It began at age 7 or 8. Why? Right? Well, best I can tell, educators had the concept of the age of reason, age 7. That's the age at which supposedly children can begin to reason and can begin to learn and can begin to take in education. And the thought was that education before that age would not stick, right? Children would remember, children wouldn't benefit. Developmental scientists, developmental psychologists, scientists also didn't understand the importance of early development. I believe that's changing, terrific progress in the past decades as we've understood neural development. And you've heard the statistics about trillions of synapses in the first several years of life, and then pruning later. So it is changing. We suggest that a third reason for neglecting families in early life is what I would call insidious racism. So I'm a middle-class white. My parents, my family figured out, even if society is not supporting us in early child development, we can figure out how to get our needs met, whether it's from the church down the street or a community center or a pediatrician or that expert, right? We're on the inside, good old boy network, know how to do it. And as long as we can get our needs met, we can neglect the needs of other groups, right? So I'm not sure how conscious that is, probably is conscious in some spheres, but I think is part of the whole story. And the last reason is perhaps we don't know what to do. Perhaps we don't know how to support families in early life, right? So that's a little background. I want to move into talking about the research by communicating to you two brief case stories, true case stories that I encountered as I entered this domain of work. First is Marisol. Marisol was a single mother living in Durham, North Carolina. She had two children, maybe 3 years and 9 months of age. And she's single, lived in an apartment by herself. She had a job as a maintenance worker, overnight shift, had a babysitter. She had a great plan. Babysitter would come every night at 10:30. Babies would be sleeping. She'd leave, go to work, come back in the morning. One evening, the babysitter failed to show up. She panicked. She didn't know what. She knew her employer would fire her first time, right, if she didn't show up for work. Babies were asleep. She locked the door from the outside of the apartment, went off to work. 2 o'clock in the morning, one baby woke up, started crying, woke up the other baby. The two of them are screaming. An apartment neighbor knocks on the door. Nobody's there. Calls the police. Police come, knock the door down. No adult. They arrested her for neglect. It was 9 months before she got to see those babies again, right? And just the whole child welfare system. What's wrong with this picture? She had great intentions. She had a great plan. She had no backup plan, right? And she had no system of support, right? So we could think about, what does Marisol need, right, in order to succeed? Second case story is Lisa. Lisa's middle-class woman, had MBA, lived outside of Durham, had an executive position. She and her husband got pregnant. She wasn't sure she wanted to have the baby, had the baby, quit her job, was home with the baby, 6 weeks of age. Husband was off on a trip, and she was exhausted. Nobody had diagnosed it, but I think she had postpartum depression. She was certainly exhausted. And one night, the baby was crying, and she was just a little slow in getting to him. She was just exhausted. She finally got to him. He had a wet diaper. She brings him to the changing table, takes off his diaper, and he pees all over her face. And in a moment, in a fit, she slapped him across the face so hard that it left a bruise, and by morning it turned purple. Being a good mother, she brought him to the pediatrician. Pediatrician figured out what's going on, called Child Protective Services, and she too was arrested for child abuse, and it was a long time before she saw her baby again. What's wrong with this picture? Her needs were being met. You can think about 15 different angles on this story. Both of these are totally preventable in a different society than we experience today. All right, lessons learned. Giving birth is both exciting and frightening. I don't know if you're a parent. I'm a parent of two. I remember the day my son Graham was born. It was the most exciting day of my life and the most frightening day of my life. I had not a clue. I didn't know that diapers came in different sizes, right? I mean, I'm educated and I had no clue, right? All right. We find in surveys 94% of families giving birth report stress and clinical needs at birth. But the needs are diverse. One family might need a crib, another family might need substance abuse intervention or intervention for postpartum depression, or simply education about how to find the best childcare, right? But the needs are diverse, but 94% of families communicate and report to us some kind of need. All right, so that tells me no single intervention, even scaled up, is likely to move the needle in whatever our dependent measure might be. And we need individualized plans. We need universal reach, but individualized plans for intervention, right? One for Marisol, one for Lisa, one for me, one for you, et cetera, right? All right. We also learned that access to community resources is limited. Neither Lisa nor Marisol knew where to go, right? So access must be universal, but also individualized. And we need a universal system to support families. Now I'm thinking grandiose, I'm thinking big, but I think this is what we need. All right, so the solution is a comprehensive system of universal primary psychosocial care. I want to draw for a moment on a couple of other, I'll call them successful systems of care. Maybe the implementation's not always perfect, but public K-12 education in the United States is a comprehensive system of care in at least three ways. One, there's a universal base. It's offered to every child, right? Regular education. Second, there's an infrastructure to provide individualized supports, right? So there are specialized services available based on individual need. Maybe it's special education for a learning disability. Maybe it's counseling intervention if there's some behavioral difficulties, right? There's a variety of, and an infrastructure for all of that, that by going to a public second grade, hopefully your family will get access to that should you need. The third part is targeted support for those in particular need. We have free reduced lunch, free reduced breakfast, right? We have after-school programs. We have all kinds of programs that understand the income disparities and can provide that support. Another comprehensive system is our primary healthcare system. Doesn't always work well, but it is a comprehensive system of care, having the same three components, I think. There's a universal base. Hopefully, you've got health insurance or Medicaid or some kind of support that provides universal access, right? I can bring my child to an annual well child checkup. Doesn't have to be sick. Universal access, right, with guidance. Second, there's an infrastructure of specialized services. So my primary care physician, maybe my child's pediatrician, will see my child, screen my child, do some brief interventions, wear a seatbelt, wear a bike helmet, eat the right foods, not too much sugar, but also say, oops, you need to be referred to an otolaryngologist, or let's get you to a radiologist to see what this problem is, or a nutritionist, or whatever. There's a whole infrastructure, right, connected by some electronic health record system. It's actually pretty cool, right, that I can bring my child and get access to these, maybe a neurosurgeon, right? And I don't have to be the one to find the care. The pediatrician will help me get access, right? That's a comprehensive system of care that I'm starting to envision. Why don't we have this for families, right? Just think about that. All right. And then, of course, there's targeted support in primary care, Medicaid for families without means, Medicare for my 94-year-old mother. Okay. So what I want to do with the rest of my time here is describe to you three different programs of research, empirical research, testing three different components of a comprehensive early childhood system of care. All right, and I'll go in a slightly different order. I'll start with the infrastructure of resources, and the intervention is something in North Carolina called Smart Start. I want to talk about financial subsidies for families who cannot afford pre-kindergarten, North Carolina's pre-kindergarten program, evaluate that. And then this universal primary care system of care, and it's the work that David referred to that I've been involved in called Family Connects, which is a universal short-term nurse home visiting program that is being scaled up in communities around the country, including Chicago, my hometown. All right, and for each I want to evaluate impact. I want to describe it to you and then evaluate impact on population level outcomes. So this is an important part of population mental health science, is the dependent variable is the population score, not 20 families who voluntarily participate in a randomized trial and are not representative of anything else, but the population score. and whether or not these interventions reduce disparities in access and outcomes. Equally important, right? Both of those. All right? All right, so let's start with Smart Start, which is an infrastructure of community resources. In the early 1990s, North Carolina Governor Jim Hunt, known as the education governor, really a wonderful man, developed a top-down statewide initiative with the goal of improving population-level early childhood health, education, and well-being by improving the infrastructure of community resources birth to 5, mostly childcare, providing lots of dollars into a community to improve the quality of childcare, to bring behavioral health, behavioral mental health to daycare facilities, childcare facilities, families can have access. It's kind of vague, right? But it's community-wide. And it really was funds best measured. The independent variable is best measured by funds allocated annually by the state to a county, right? For use in improving the standards for childcare agencies, supporting community agencies to address family psychological functioning. And they focused on all children, not just low-income children. All right? What's interesting about Smart Start, this is a dollar program, is that as a lot of things in government and state government, it's pretty haphazard. And so the distribution of the dollars was haphazard across the 100 counties of North Carolina. Initially by design, they scaled it up. They began with 9 counties, and then 34 counties, and then 57 counties, and eventually all 100 counties. And, you know, they try to have one county in each elected representative's district, so it was pretty distributed, and we think pretty independent of anything about a particular child. Exogenous. Makes for a natural experiment, because you have the state giving more dollars to one county than to another county, both within a year as well as across years. So graphed here, this is the mean, but these error bars or range gives you the range of dollars on the left side per child. We've calculated as dollars per child in the population, right? 0 to 5. Ranging from nothing to hundreds to, you know, $800 per child per year. All right. On average, it was $220 per child per year across 5 years that a child would go through this. $1,100 per child is how much the state was giving to a child, with a lot of variation. So we use the variation as a natural experiment. That's the independent variable. And the dependent variable is the population-wide reading test score in 3rd grade and math test score in 3rd grade, and absenteeism rate and special education rate and grade retention rate. So these are population scores taken from administrative data. All right, so I've already described this to you, right? The independent variable is the state funding. The outcome variable are our reading and math test scores. We had 13 cohorts of births. Imagine the design on the right there, where you've got a bit of a matrix. Each year, school year, 90, 96, 97, et cetera, all the way through 2008. And then we had each of 100 counties. So in that matrix, each county year got a different funding level. Right? And we correlated, or in a natural experiment way, related that independent variable to the outcome. There's our model, right? We have a 5th grade outcome. And on the left side and on the right sides, the amount of Smart Start funding per child over 5 years. And then we've got covariates. And we use county and year fixed effects to take into account any unaccounted for, unmeasured third variables that might be confounding our analysis. All right, here's a simple graph on the right side. I've got a graph for the white children and the black children separately within North Carolina. Remember, this is over 1 million children now. And we find that as the amount of funding across counties and across years increases, so do the test scores. All right. It's a modest effect, or actually, depends on how you want to think about it. It's the average level of funding was associated with an increase in reading test scores by about 2 months of learning. All right, so take them how much learning or increase in a test score a child displays across a year, and this $1,100 increases the test scores 8 years later by about 2 months of learning, right, or a fifth of the school year. That's a pretty good investment when you think about how much public education costs, right? And the funding increased the scores for both Black and white children. Wonderful. But there's really, those two lines are pretty parallel. There's not really much convergence or disparity reduction, right? All right, conclusions. Modest investment of funds, $1,100 per child, in an infrastructure of early childcare, daycare, education, associated with a significant modest increase in enduring population academic achievement for all the groups of children that we studied. The investment alone does not reduce disparities, but it's a great start. So we conclude policy-wise to continue it and to supplement it. So now let's go to the next part of our three-part system of care. So the second part is providing extra financial support for access. Here I'm evaluating North Carolina's pre-kindergarten program, which is a program in North Carolina for 4-year-old children, for children who meet a standard of low income. And they essentially get a voucher to attend a certified pre-kindergarten classroom. The classroom has to meet the standards of teacher salary, class size, health standards, educational curriculum, a number of different criteria. One effect, by the way, was to increase the standards for the statewide pre-kindergarten programs in North Carolina because they wanted these vouchers, right? If you're the Epworth United Methodist Church basement pre-kindergarten, you want those vouchers to bring in money, right? Or if you are the local public school and you want to start a pre-kindergarten, you want those vouchers too, right? So there's in a mixed delivery system, these pre-kindergarten classrooms were all over. They did not create new classrooms, but they used existing pre-K classrooms and gave them vouchers to have children come into those. What it meant is that low-income children are in the very same pre-kindergarten classrooms as middle-income children. There's no money being given to the middle-income children, but the standards are being raised. Maybe there's a positive effect on them too, right? But this is part of that financial support. All right. Like Smart Start, North Carolina's pre-kindergarten program was scaled up haphazardly, partly by design. There were pilot communities, 1 year and then more the next year and more the following year, and partly because they just were pretty haphazard in distributing the funds. So here again is a graph of the average funding is the green line, and then the range is in the bars. The funding ranged from $0 all the way up to several $1,000s. Interestingly enough, about 25% of the children in a community, average community, got these vouchers. So it's for low-income kids, but not only the lowest of the low, but about 25% of the population. And the vouchers averaged about $4,400 per child per year. If 25% of the kids got a voucher, that's about $1,100 per child in the full population, if you're following my numbers, which ironically is about the same as the Smart Start program. But so an investment of $1,100 per child for pre-kindergarten in the full population, right? Does it have an impact on these later test scores? Here's the graph. Now I have graphed here both the middle income and the low income groups, right? These data are taken from administrative records from our education record data center at Duke. And the bottom line is the low income children. Those are eligible to get a voucher and get a slot. You can see that the more dollars their community was exposed to, not necessarily them, but their community, right? The higher their test score for the low-income children. And interestingly enough, there was also a positive effect on the middle-income children in that same county year cohort. Even though none of these children got a voucher for pre-kindergarten, there's a spillover effect on them, either because now they're being exposed to higher performing low-income peers, or they're also attending these pre-K classrooms that have increased in their standards, or maybe the kindergarten teachers now can teach to a higher level because the low-income children are coming in with a higher level of kindergarten readiness skills, and the teacher can start from a higher level, and everybody, I don't know the mechanisms, we're still trying to study that, but you can see there's also a positive effect on the middle-income children. Not as strong, and so the result is disparity reduction, right, by 38%, right? These lines are starting to come together. It's really a policymaker's dream, right? You have a positive impact on the low income. You also have a positive income on the middle income who are going to vote and keep you in office, et cetera. And you're going to achieve the goal, or start to achieve. I won't say actually achieve, but you're going to move in the direction of achieving the goal of a disparity reduction. All right, so that's the value of targeted support. Let me go to the third of the three programs of research that I'm really most excited about. It's my baby. It's what I've been working on with colleagues for the last 25 years, called Family Connects, Universal Primary Psychosocial Care. We began in 2001 through a commitment by the Duke Endowment, private foundation, not affiliated with Duke University, but it's the same dear old Mr. Duke. They came to us and said the child abuse rate in Durham, North Carolina is too high. It's higher than the North Carolina average, which is higher than the nation's average, and it's despicable. Can you reduce it? And we said we didn't know how. And they said, how long would it take? I said, I have no idea. It might take us a decade. So on a handshake, they promised us a decade worth of research funding to try to solve this population problem. As long as we met three criteria. First is that the metric must be the population level of child abuse, right, by Child Protective Services, not just 20 families that participate in a voluntary randomized trial, but the whole population. Second, that we must manualize the intervention so we could bring it to other communities. And third, that we evaluate it as rigorously as we can, hopefully with a randomized trial, but whatever rigorous empirical way. So we took it on and spent 8 years making a lot of mistakes, trying different ideas that I'd be glad to talk with you about afterward that didn't work, failed. And ultimately, we started 2001, right around 9/11. And in 2009, we began our first randomized controlled trial. All right. All right. So what is Universal Family Connects? I think it's a paradigmatic shift. That sounds pretty grandiose, but I'm excited about it. And so I get to be grandiose about it. That has these three pillars: a community resource infrastructure. We said, okay, all community agencies and community resources, birth to 5, we've got to bring you together to all move in the same direction. We started the Wednesday morning breakfast club, we called it. They assembled in our shop, the superintendent of schools, the community mental health center director, the chair of the county elected county commissioners, the sheriff, the police chief. Those are two different offices. They compete with each other. A number of community leaders to align themselves and to devote themselves. They're connected now in electronic data system, integrated data system that we have so they can communicate with each other. There's an electronic directory of over 400 agencies in Durham now that are aligned and devoted to supporting families at birth. Right. Second, improve access to specialized care for all groups and individuals. So we got targeted either dollars or vouchers or spots and slots in childcare agencies, et cetera, for low-income families. And we delivered what we call universal primary care. All right, think about Maricel, think about Lisa, think about me and my needs, think about every community, every family giving birth in the Durham community. We want to reach all of them, right? But we can't deliver the same thing to everybody because Lisa and Marisol have very different needs, right? So we developed the idea of universal nurse home visits, 1 to 3. We invited ourselves into the home in the hospital an hour after giving birth. At about 3 weeks of age, we'd like to invite ourselves to come to your home. We're going to have a little gift for you. We'll bring some diapers and they will be sized right for your baby. And we'd like to spend a couple hours with you, supporting you, getting to know you. 80%, 81% of all families in the community accepted our offer, believe it or not. It just shows how exciting and frightening and needy this time in life is, right? And so we, during that home visit, use a structured interview. We called it a guided conversation with some screeners and all to identify family needs. Maybe they need a crib. Maybe they need postpartum depression intervention. Maybe they need a backup plan for babysitting. Maybe they need education and what good childcare should be about, right? Whatever. So the nurses gave them some of that education and also connected them on a case, family by family, case by case basis with community resources. All right, Mom, you've just described to me how you're feeling what you call the baby blues, and you're kind of lacking in sleep and lacking in energy, and maybe you want to do something about that. Let's talk about some options. There's a mental health center with a trained professional who could maybe give you a pill or maybe give you some talk therapy or whatever. Would you like to go there? Or maybe you'd rather have a parent support group of other mothers of babies, right? What would you like? So we'll make the referral to you. You go to that, oops, I'm on the phone. I got an appointment for you for next Tuesday at 2 o'clock with this mental health provider. Great. You go there. You need transportation. You need help in getting there. If not, okay, you go there. I'll call you Wednesday to see how it went for you. That'd be all right? It's all voluntary. Right? Okay. That's how it goes. We structured it with 12 different factors listed on the left there in 4 domains about maternal health, infant health, health care plans, childcare, parent-infant relationship, management of infant crying, household supports, family safety, depression, anxiety, et cetera. And then on the right is some possible community connection, right, that's matched. And the nurse learned this matching. You can see here, I've got in green, Maricel, right? She needed childcare planning for the babysitting overnight, right? So let's educate her, talk with her about emergency childcare. That's a thing I didn't even know it existed, but exists, right? If you can pay for it. There's also backups for her. She needed planning. Or Lisa, right? She had postpartum depression. She needs mental health services, right? So you get the idea of individually matching. This is manualized. We have a several hundred-page manual. Nurses are trained to follow this. But there's also some room for flexibility. Here's 2 examples of flexibility, right? First is understanding a mother's experience of racial injustice. So Felicia was one of our nurses, and she wrote, you know, health, this is what she tells Black mothers in Durham. Health disparities in our community are prevalent. I explained to a mother, if she feels like something's not right, she must learn to advocate for herself so that she can be around her children that need her. And Felicia would help connect her. Of course, in COVID, we had to adapt to virtual home visits. We've returned now to in-person, although some families still don't want us in their homes, and so we have to be flexible. How do we evaluate it? Well, the first way we evaluate was a non-randomized. We're just comparing the Child Protective Service investigation and substantiation rates in Durham, right, through state statistics for the county of Durham for infants birth to age 1, right, which is the green line, right? And the perpendicular line is when we started. And then we used a 5-county comparison group in the rest of North Carolina in the red line. And you can see in the baseline period, the two groups overlapped a lot. And after our intervention began, the green line went down by quite a bit, and the red line stayed pretty stable. Wow, we were excited. These are non-randomized data. Maybe Durham differs, so we're excited, but we want to do a randomized trial. So the next thing we did was a randomized controlled trial of Family Connects. And the first trial, RCT1, this is important about population mental health science. It's one thing to do a study with volunteers who know they're in a study with an IRB and they sign consent and they agree to participate in the study, and they do, and that's a smaller number, usually not representative of the community. They know they're in a study. They think they're getting something super. There's a lot of placebo effects. That's fine, well, good. But to do population mental health sciences, we randomly assigned every Durham resident birth in Durham across an 18-month period to the intervention or control condition, right? How do you do that without consent in an IRB acceptable way? We randomized by date of birth. The baby was born on an even numbered birth date, they were assigned to the intervention. They're born on an odd numbered birth date, they're assigned to control. All right. We did some research. Babies born on the weekend don't do as well as babies born during the week, but there really is no difference between even and odd birth dates. Right? Ideally, and this is the study I'd love to do in the future, is I'd rather randomly assign entire communities. But now we're talking expensive and we're talking a different realm, but I hope that's where we go. But this was randomly assigned within the community. We implemented the Family Connects intervention. 81%, as I said before, agreed to consent, participate, and have a home visit. Of those, 86% completed the program. During our visits, 94% of families identified at least one need. About half of that, 94%, were resolved by the nurse. Here's what you look for in a good childcare. My computer tells me there are 3 5-star rated programs, and you want a 5-star rated program between your home and your work. We want to go visit one, education, right? The other half were resolved, were serious and resolved by a referral for ongoing intervention to a community agency, maybe a mental health provider or whatever. All right. Our data analytic model is intent to treat regression models with interaction effects, ordinary squares, logistic regression, depending on the dependent variable, with a bunch of covariates, right? Our outcome measures, most important, are condition-blinded parental mental health interviews when the child's 6 months of age. Now, the intervention starts at birth and is over by 8 to 10 weeks of age. So our first outcome period is when the baby's 6 months of age. And then we also used administrative records to follow families over time, looking at emergency room, medical care, dollar costs, child abuse, child protective services records by age 60 months. And as I like to say, because this is community-wide with administrative records, I could wait till the babies are age 18 and find out whether the high school graduation rates for even birth dates are higher than for odd birth dates. Wouldn't that be cool to see, right? But that's part of doing population mental health science, I think. All right, and then of course we want to replicate it. So we've got a second RCT. All right, findings, and then I'm going to move to close so I can get some questions from you all. On the graph on the right, the randomly assigned control are on the left, those assigned to Family Connects. This is intent to treat, so everybody, not just those that participate. For Black families and white families, and you can see that for both Black and white families, those assigned to Family Connects show lower maternal anxiety, depression, disorder, symptom scores by about 34%. And wow, we closed the race disparity by a lot in this first study, right? So we're thrilled. One or two more graphs. These are emergency room visits for the child for injuries and illnesses, right? Falling down, maybe child abuse, maybe not, we don't know, maybe an illness, whatever. And you can see again for both Black and white families that Family Connects assigned families show a significant reduction by about a third. We're not closing race disparities here by much. And then child maltreatment investigations. So these are state records from Child Protective Services, right? The red line is the controlled mean. These are cumulative mean investigations across the child's life from birth all the way up through age 5. So the red line is kind of the normal life course of investigations for child abuse for control families. And the blue line is those assigned to Family Connects. So we've got a decrease of abuse investigations by 39%, and we're modestly closing the race disparity in abuse. All right, we want to replicate. I'll go over this very quickly. So we replicated it several years later with a similar design. Now, odd births got the intervention and even births were the control. We implemented again with similar levels of participation. 76% of the community this time agreed to participate, and 82% of those completed it. 92% report a need. Same kind of data analytic model and dependent variables. Just very quickly, this is emergency medical care. We followed them here through age 24 months. We're still following them, but it decreased. Random assignment to Family Connects decreases emergency medical care by about 32%, closes the race disparity modestly. Also, we get decreases in child abuse investigations. The blue line for the white families is very low to begin with. All right, brief benefit cost analysis. Family Connects intervention costs about $700 per family community-wide. There's an art to this. How do you develop a universal intervention that's costly enough and expensive enough and deep enough that it has an impact, but less expensive and modest enough that it stands a chance of being implemented and disseminated, right, community-wide, right? So we're not throwing too much at it. In any case, emergency medical care building is about $3,500 per visit is on average the cost of infant emergency medical care, et cetera. Briefly, you can see that the benefit cost ratio calculation, pretty simple, is for every dollar spent, the Durham community saved $3.17 by the time the child was 12 months of age. All right, what are we doing now? And I'm going to close. Communities have read our scientific articles and have come to us. They want Family Connects. So we created a nonprofit organization to disseminate it. And what's graphed here, depicted here, we're now in 53 different communities around the nation, 22 different states, reaching about 3% of the nation's births. And if we go to scale in each of these places, we'll reach about 10% of the births in America. About 4 million babies born in the United States a year. So we're scaling up to reach 400,000 births. You know, the moon is what we want, everybody. So we'll see. The blue states are the ones where we are actively implementing. This is actually a little bit old. The green are being planned, and the yellow are contracted. We're growing. We're here in Chicago. I think we're in 11 hospitals now. There were 19 hospitals in Chicago that gave birth. When we began, 3 or 4 of those have stopped giving birth. Holy Cross Hospital on the south side, where I was born, used to have birthing facilities. They've cut that out and don't have that anymore. That's too bad. But we're scaling up in Chicago through wonderful support from the Department of Public Health. We're scaling up for the entire state of Oregon, about 45,000 babies born a year there. The entire state of New Jersey, Ohio, New Mexico, Maryland. It's growing. And wow, is that a challenge? And so here's our research agenda. This is my last slide, right? How do you build out this concept of early childhood system of psychological care? First, we want to build a lifespan primary care system, kind of like healthcare, maybe integrated to healthcare, seeing families not only at birth, but families have told us they wish we had started prenatally and they wish we wouldn't go away and stay with them to kindergarten. So Think about annual home visits to do the same kind of thing, right? Which we are now demonstrating in Guilford County, North Carolina, Greensboro, North Carolina, where, believe it or not, there are a bunch of, there's a national group called Blue Meridian Partners, 8 billionaires, including Steve Ballmer and David Tepper and Stanley Druckenmiller, who are giving $130 million to Guilford County to build out this system and demonstrate it. It's not a randomized trial, so we are doing a randomized trial in Durham, North Carolina, with 800 families. The Duke Endowment is providing the intervention dollars. NIH is providing the evaluation dollars. All right. Want to figure out how to embed this system into healthcare? We can't start a whole separate system. Just functionally won't work for communities. So we're working with OBGYN prenatal care, pediatricians, the Healthy Steps program, and building out this family-based electronic case record. Think about it, a family electronic case record with all the services the family has to support their baby birth to 5, connected. So the community mental health centers connected to Head Start, just connected to the pediatrician. So Head Start can tell the pediatrician the 3-year-old child hasn't come to Head Start in the last 19 days in a row. Do you know about it? What's going on? Can we coordinate? All voluntary, all consent, all HIPAA-proofed, all cyber secure. Got to figure all of that out. We got to figure out how to finance the system. I love what we've done in Oregon. All right. In Oregon, the state legislature passed legislation that mandates Family Connects on a voluntary basis for every baby born in Oregon. 1/3 of the cost is picked up by the federal Medicaid program, 1/3 by taxpayer dollars, and 1/3 by private, commercial, for-profit health insurance, Kaiser, Blue Cross. And they didn't resist it. Maybe they know it'll actually save them dollars, but it's a 1/3, 1/3, 1/3 arrangement. All right. We know we need to adapt it. Gosh, we're working with tribal communities in Eastern Oregon. You can't go into a home in a community of tribal families without getting support from the elders, right? And you've got to really understand. I don't know this, but I know that we've got to know this, right? So we've got to figure out how to adapt it and be modest about that. And then we've got to evaluate implementation and impact rigorously. As I said, my next dream, don't know it yet unless you've got some money to pony up, is how we randomly assign communities, right, to this so we can truly do it at scale in that way. With that, let me stop and invite you to give comment and questions. Thank you for your time today.